Hello and welcome to the European Respiratory Journal podcast. My name is James Chalmers and I'm the chief editor of the European Respiratory Journal. Every month we discuss a new paper that's published in the journal in detail with one of the authors. And this month I'm delighted to be joined by Marius Hoeper from Hanover in Germany, who's going to be talking to us about his study just published online at the ERJ. This is the efficacy and safety of sotatercept, a pooled analysis of the PULSAR and STELLAR studies. Welcome, Marius.
Hi, James. Thank you for featuring this paper.
So really pleased to have you with us and delighted to publish this paper. Some of our readers, particularly those who don't work in the field of pulmonary hypertension, won't be so familiar with sotatercept. So maybe kick us off by telling us a bit about what is this drug and how does it work?
Yes, sotatercept is a new treatment for pulmonary arterial hypertension. It was originally developed as a treatment for some forms of anemia, but then it moved into an entirely different direction, which is, as I mentioned, treatment of PAH. And sotatercept is a fusion protein, so it's composed of the type 2A activin receptor, which is bound to the Fc fragment of human immunoglobulin G. And it acts as a ligand trap for molecules that are involved in pulmonary vascular remodeling, so especially the activins A and B, but also some growth differentiation factors and some bone morphogenetic proteins. And everything here contributes probably both to the efficacy as well as the safety signals that we see.
How does it differ in terms of how it works from some of the existing drugs, because of the number of drugs that work currently for pulmonary hypertension? As I understand it, it's maybe less on the vasodilator side, but more actually targeting the fundamental problem, the remodeling. Is that correct?
That is absolutely correct. First of all, it's not a vasodilator at all. The effects really by binding these, especially the activins, which are growth factors and survival factors for the endothelial cells and the vascular smooth muscle cells that obliterate the lumen in patients with PAH. So PAH, the pulmonary vascular disease component here is really vascular remodeling, but it's not so much fibrosis, it's proliferation of endothelial cells and vascular smooth muscle cells. And the concept here is that really by inhibiting this process and the growth factors necessary for this progress, that we can not only delay the progression of the disease, but we can probably at least partly reverse this kind of remodeling because the cells, they just go into apoptosis or other forms of cell death. And there's so some partial reopening of the vessels, which is very fascinating.
Yeah, it is fascinating. So that's the theory. So the reality is what you've explored in the study that you published in the ERJ. So this was a pooled analysis of the phase 2 study, which is called PULSAR, and the phase 3 study, which is STELLAR. So tell us what you did and what you found.
Yeah, this is entirely correct. So PULSAR was the phase 2 study published 4 years ago in the New England Journal. It was a study that enrolled prevalent patients with PAH, heavily pretreated, almost all of them on double or even triple combination therapy. Patients were quite stable in functional class 2 and 3, and they received either sotatercept or placebo on top of the background therapy. There were 2 different dosages in that study. So there was a dose of 0.3 and another of 0.7 milligram per kilogram of sotatercept, which is administered subcutaneously every 3 weeks. In that study, the primary endpoint was changed from baseline at week 24 in pulmonary vascular resistance, PVR. And the study met its primary endpoint. There was quite a substantial reduction in PVR, about 3 Wood units with the higher dose arm and 2 Wood units with the lower dose arm. And STELLAR was the pivotal phase 3 study, very similar inclusion criteria. So also patients functional class 2 and 3 and with the historical diagnosis of PAH heavily pretreated. The study had a different primary endpoint, change in 6-minute walk distance, again from baseline at week 24. But it also had the endpoints that we had in STELLAR, including the hemodynamics, and then time to clinical worsening, which was not obtained at week 24, but when the last patient completed the study here. And in PAH studies, one of the problems is that we don't have that many patients. So we don't have thousands of patients as like, for instance, in heart failure studies. We usually just have a few hundred. In fact, we had 106 patients in PULSAR and 323 patients in the STELLAR trial. And as these numbers are very small, it's important to do these combined analyses in order to get more robust signals, both on efficacy as well as on safety.
So to complete the story, in addition to what you've just told us there, you've recently published a further randomized controlled trial in the New England Journal of Medicine called Zenith, looking at patients at very high risk. I wonder if you want to tell us a little bit about what was found there.
Yeah, sure. Yeah, as mentioned earlier, in the previous studies, PULSAR and especially STELLAR. STELLAR was a study which, by the way, led to the approval of sotatercept for the treatment of PAH in the United States, in the EU, and in many parts of the world. But this was a study that enrolled, as you mentioned earlier, only patients in functional class 2 or 3, so stable patients, and usually in the intermediate risk of death. And it's interesting because in the United States, the drug has been approved for PAH irrespective of the functional class, so for all functional classes. In Europe, however, the EMA approved sotatercept only for the treatment of patients functional class 2 and 3. And now here comes Zenith, because Zenith is an entirely different study and included, as you rightly mentioned, patients that presented at enrollment in functional class 3 or 4. And they had to be at a high risk of death, which was determined by the REVEAL Light 2 score, which is an established risk prediction tool in our field. And so the patients were much sicker and had a much higher risk of death than the patients in previous studies. And usually these patients are not enrolled in clinical trials in our field. In addition to that, the primary endpoint was also different from previous PAH trials, as for the first time, we chose to select a robust composite endpoint of outcomes, which was a composite of death of any cause, lung transplantation, or hospitalization for at least 24 hours for worsening of pulmonary arterial hypertension. So the other components like worsening in 6-minute walk distance, which were part of previous PAH studies, were not a part of this. And I think this is quite important here. This study, again, enrolled patients who were stable, pretreated, heavily treated, in fact, pretreated. In fact, most of the patients were on triple combination therapy. And this was one of the main inclusion criteria, that they were on maximum tolerated therapy. So most of these patients were on triple, which is currently considered the everything that we can do, especially if it includes parenteral prostacyclin analogs, which was the case in these patients. And these patients were again randomized 1-to-1 to receive either sotatercept or placebo on top of their background therapy. And here, sotatercept also proved quite effective. In fact, that study had a planned interim analysis after about half of the pre-specified events had occurred. And at that time, the signal was already so strong and statistically significant that the data monitoring committee recommended to the sponsor to terminate the study. And the steering committee agreed to that, which is why this study was prematurely terminated. But again, with the very clear signal, there was 76% risk reduction in this composite endpoint. You could even discuss the mortality signal, which is formally not statistically significant here, but it's quite strong data, together with the data that we have here, including this combined analysis published in the ERJ, looking at PULSAR and STELLAR combined.
Yeah, the story seems to be quite consistent. And as you've emphasized, it's impressive. This is a benefit on top of standard of care, which already includes a number of treatments. Just for balance, I guess we should also mention safety. So have there been any safety issues arisen in any of these studies?
Yeah, this is still one of the hot topics in our field, because as with any new drug, which this is constantly evolving. And I mean, we're targeting a system here that we have never addressed before, not only in PAH, but in any field of medicine. And so we're learning by doing and looking what happens to the patients. And in the first study, PULSAR, part of the paper here, there were very few side effects in this first 6-month study. But over time, we learned then from other studies, and these ones, of course, that sotatercept has a unique side effect profile. I mentioned earlier that it was originally developed to treat anemia in some forms of myeloid cancer. And so one of the side effects that we see is an increase in hemoglobin. And it is a side effect in an adverse event, but usually it's not clinically relevant, although every once in a while you have to adapt the dose. Thrombocytopenia can also develop. It's usually mild, no problem, but occasionally you also have to modify the dose because of that. Then about 20% of the patients on long-term treatment develop cutaneous telangiectasia, usually affecting the skin and the chest, but it can affect all parts of the body. It's mostly mild, but in some occasional patients, it can be quite extensive. And then there is bleeding, especially epistaxis and gum. It's mostly mild, usually not requiring any intervention, but nevertheless, it's part of concern. And this is not related to thrombocytopenia. It's probably vascular, and it's probably a similar mechanism as telangiectasia, which is the development of more fragile vessels, probably in our mucous membranes, especially in the nose. And some of the features, the nosebleeds and the telangiectasia, resemble what we see in patients with Osler's disease, so HHT or heritable hemorrhagic telangiectasia. It's very similar, and we believe that some of the binding properties of this compound, especially the binding of bone morphogenetic proteins 9 and 10, contribute to this. And then very recently, some case reports have emerged which link sotatercept to the development of delayed hypoxemia with a very similar mechanism as we see in patients with the so-called hepatopulmonary syndrome, which is interpulmonary vascular dilatations. And this has been reported only a few weeks ago in 2 patients treated with sotatercept. It seems to be a very rare adverse event, but it's certainly something that needs to be monitored. And this is highlighted for patients being treated with sotatercept. It seems to be reversible with stopping or halting the drug or reducing the dose, but we have to learn more about it. And then also there has been some discussion about the development of pericardial effusion with activin signaling inhibitors. In fact, this was not observed with sotatercept initially. There was a second generation activin signaling inhibitor that was tested in a phase 2 program. And there quite a strong signal emerged, suggesting a relationship between this compound and the development of pericardial effusion. And now there are some emerging reports about the development of pericardial effusions also with sotatercept. The problem is that pericardial effusion is not so uncommon in patients with pulmonary arterial hypertension, especially in those with advanced disease and more advanced right heart failure. So what we've done recently is we looked at the echocardiographic data, which we have from all patients in these trials, so the phase 2 and the phase 3 trial program. And this is currently being submitted and hopefully published soon. And at least here, in this randomized controlled setting, over extended periods of time, we don't see any signal suggesting that sotatercept increases the risk of pericardial effusion. But then again, it is still possible that this is maybe a rare side effect in some patients, especially in patients that are at a higher risk, for instance, patients with connective tissue disease, such as PPH. So this was a very long answer. It's complex, but it's very important.
No, I think that's incredibly important. So we talk a lot about the efficacy. It's also important to know that people are looking very carefully at the safety of new drugs. And I think the answer you've given is really reassuring. So with the very convincing data published in the ERJ and also in other papers, this is clearly now moving forward. It has regulatory approval in the US and in Europe. Where is it fitting into the treatment algorithm at the moment? And do you think there are still some unanswered questions?
Oh, yeah, a lot. This is work in progress, of course. The clinical trial design was that sotatercept was used as add-on to established therapies. I mentioned that double or triple combination of therapy, and fairly late. For instance, in the pivotal study STELLAR, the interval between the initial PAH diagnosis and enrollment in the study was about 8 years. I mean, these were survivors, patients living very long with pulmonary arterial hypertension. I mean, given the efficacy of this treatment that we see across all clinical trials, I think this will not be the place where sotatercept will be used in the future. For the time being, we have no data on initial use of sotatercept, either monotherapy or initial combination therapy. But this is going to come, and this is one of the unmet needs you mentioned. But for the time being, I think the standard of care will be for most patients, a diagnosis of PAH is made, initial oral combination therapy with an endothelin receptor antagonist, and a phosphodiesterase 5 inhibitor is initiated. And then the patient is reassessed, usually after 3 to 4 months of this treatment. And if the patient meets all the treatment goals, so it's clearly low risk and right heart function has improved substantially, and these patients remain on this oral combination therapy, and this will apply to about 20% of all newcomers. But for all other patients, so the remaining 80% of patients, they need something in addition to that. And given all the data that we have right now, including SENES, which is the first study that shows that sotatercept is really effective also in patients at high risk of death, and we don't have this for any other of the treatments that we use, including intravenous prostacyclin. I think for many physicians, but also patients who ask for that, sotatercept will be first choice in the future.
Fantastic. Everything you need to know about a new treatment for pulmonary arterial hypertension. I'd like to thank Marius for joining us and sharing his knowledge with us. You for joining us in this month's podcast. Join us next month and every month as we highlight a new paper in the ERJ and dive deep into the science. Thanks for joining us. See you next month.